falls. It's rare, but when it happens, we have to take it seriously. And then the catheter just can kind of, it can, every time you do a dressing change, just come out a little farther till it's not in the SBC anymore. It can also go from the SBC, it can flip up sometimes. And I just exchanged one the other day that they'd had for 3 weeks, and then a random chest x-ray showed that the PICC had flipped up into the jugular. So sometimes they can be flushed down, but unless you have a way to check it and flush it and check it with the x-ray, I just usually exchange it. So daily maintenance, we tell you to assess the site every 2 hours. A lot of times, some places use bio patches where you can't actually see the site. Otherwise, but you are looking for any swelling, any kind of redness, maybe lines going up it. We suggest that you measure around the arm and document every 8 hours and check the external length of the PICC line. We're going to give you a document when we get done, and it asks for the length of the PICC, which comes in handy when you pull it. You just want to make sure that it's the same length. We might cut it. When I cut a PICC, we cut it to size. I take a generic measurement from where I'm going to insert to about here. And then when I insert sometimes, though, I may get it right where I want it and find out I'm going to end up leaving, say, 2, this is marked in centimeters, 2 out. That's the external length. That's what you want to measure, is just the length from that to where it's inserted to make sure it hasn't come out farther. And that's what you want to check. It says every 8 hours. If the PICC doesn't get caught on anything, it shouldn't change. But we're also going to document that. We're going to document the length of the catheter, which is what we've cut. We're going to document how much went in. If I cut it at 40 and I put 38 in, I'm going to put 38, and then I'm going to have 2 as the external length. Then when we measure above the site and document the centimeters of the arm circumference. And this is to give you something to check if you notice some swelling. We're going to document that distance around the arm. I usually go what I call 2 centimeters above the site. So if it's inserted, I measure right there, 29. And if you go and measure that and it's 40 or, well, 30, even 32 or 3, something's starting to make the arm edematous. If they want to do a Doppler or something to make sure there's no clot, because wherever this PICC is, they can get adhered to it and cause an occlusion, and it'll start that swelling. Usually if it's swelling, it doesn't mean that it's infected. I mean, that's just a slower process. That's more going to be redness at the site, and then you monitor like temperature and things like that. And a lot of times if somebody starts getting fever and all that stuff so far down the road, the doctors will just pull the lines out when they're trying to get rid of anything that might be causing that. But the systemic infection, of course, is one of the main things that we want to avoid when somebody has a PICC line in for any length of time. We access them all the time, so they just have a risk of getting infected. For the blood clots, we want to encourage that they use the arm. We usually will put them in the dominant arm if we can. As long as somebody uses both arms, I'm not too picky, and I let them kind of choose, because a lot of people just don't want it in their dominant arm. But if someone has an arm that they don't use, we don't insert a PICC line into it. It just doesn't have good blood flow. We also don't insert any kind of line. This is the same as IVs in anyone that has a mastectomy or a dialysis shunt, I think are the main things. Or if it's an injured arm, contracted, we try to avoid anything like that. It's hard to do too, but. So we want to flush it. Tasha and I were talking about the heparin a little bit. So this is just, I'm going to give you my view on it, and you can give me some feedback on it. I come from the years where we used to heparinize every line we did. And we messed up some people's bleeding times. So they took it away from us and said it's bad. No, we don't use it, just saline. But with a PICC line, and with an IV, if you know, it clots off, then you start another IV, but you really don't want to lose a PICC line. And some people develop those fibrin sheaths really fast. In a day or two, you'll notice a sluggishness in the PICC. So, you know, I feel that, you know, I mean, heparin can be used. They now have a very low dose. It's only 10 units per cc, not the 100 that we used to have. That if you notice somebody, you know, having kind of some problems, maybe it's sluggish, to go on ahead and heparinize it so that the PICC stays open. It's cost effective, it's good for, you know, I mean, we're not gonna mess with their bleeding time too much, and we don't wanna lose the line if we can help it. Trying to think what else I was thinking about the heparin. Of course, you have to check for their allergies. There's a few people that now are allergic to heparin. But, and I think Tasha said that you guys can use it if indicated. And to me, an indication would be either a line that's not being used very much. We might put a double in and one line. If you have a double, alternate the ports. Don't use just one for blood and one for the meds, because they need to be flushed often and used often. The only time you separate a line is if one's used for TPN, and then you don't want to use it for anything else, but it needs to be flushed well. But both lines should be used as much as possible. But if one, you know, if you're not using both lines, then whatever one you're not using, you might put in a dose of heparin. We suggest that you always use 10 cc syringes, and this has to do with the pressure, that it helps keep the line open and decreases too much pressure that could cause breakage of it. I've not seen a PICC break, but it theoretically can happen. I'm sure it has happened, or they wouldn't be so worried about it. We don't want you to open the syringes and leave them. Open it and use it. Keep it sterile. It suggests to aspirate before you draw your, try to make sure you have a blood return. But sometimes if you don't flush, you're not going to have a blood return. So, you know, I kind of think that's one of those things they sat at a table and decided. And a good flushing will give you a blood return. A lot of times, you know, so you prep your site, make sure it's good and clean before you use it. Do you guys use these little winch caps?
We have blue.
No. Do you have them? Alcohol caps? Okay.
Those are the-
Okay. And, you know, they're nice if you have them, they're not great if you don't. And if you don't know how, I mean, some places, once they're used, they're throwaway. And all it is an alcohol prep. That's all it is just that way when you take it off, your line's been prepped. But if I go to aspirate on a line and I don't, oh, that's the wrong one, and I don't get a blood return, then I'm gonna flush it.
If you have a fibrin sheath, say it doesn't aspirate that,
Right.
that you just
And it
toss it in a
happens,
flap, yeah.
but you always want to have a blood return. So when that fibrin sheath, and this is, when I flush a PICC, and this is just something, I mean, kind of surprised me, but if you just flush one like that, it flushes. But if we call it a pulse pause, and it just kind of turns the tip a little bit, and just helps flip the end off a little bit. And I can open a lot of PICCs just by doing that.
And if we can't get it open, we can't get that.
If you don't get a blood return, you ought to activate it, because you should always have a blood return on a PICC line. And as I say that, you know, I go and see, you know, a lot of places, if they can run the medicine in, but we want it, because it's starting to build up. If you don't have a blood return, it's starting to build up that sheath. You know, I mean, I suppose in real life, if they're leaving tomorrow and, you know, it's still working, that's all up to you and how you know. But if they're going to have a PICC line for any length of time, we want it to stay clean and have the good blood return. I go a lot of places and people are getting stuck for blood because the PICC line doesn't give it anymore, you know. So one of the uses of a PICC line isn't being used because they're not getting the blood out of it. And frequently, though, when I do that pause, flush, I'll get a blood return. And don't even have, I've been called to exchange PICC lines that all I had to do was flush them. And, you know, what people aren't told, I mean, just little things, you know. It's not a matter of you know, they're bad and whatever, it's just a matter of they're busy and they don't know. And it's pretty simple. So try to tell them, I mean, that alone does wonders, is just doing that push-pause method when flushing. And then when another thing we suggest that you do, let's see if I can, okay, that's a valve. These are both valve. Let me see if I can find one that's a non-valve. Just to show you another flushing technique that will maintain the line a lot longer. This is the midline. And it's non-valved, and this is what we usually put in when we travel. A couple places we go want the valved ones, which supposedly don't need to be flushed as often. But with a valve PICC, when you flush it and you get right about down to the end of the flush, before you're done, you clamp it. And then that keeps the saline clear down to the tip. Whereas if you like flush to the end and stop and clamp, it retracts up just a little bit. And you know, if you clamp while you're flushing to the last cc, I didn't expel the air, and of course that's a no-no. But just when you get down to that last cc, go on ahead and clamp, and it'll force the saline down to the end of the PICC. And that's another thing that helps that fibrin sheath kind of stay on the outside, not on the inside. All right, we want to change the dressing. When I put a PICC line in, if it bleeds, I'm going to put gauze at the site. Try not to. Most of us don't use a scalpel anymore, so we don't like nick into the skin. We kind of numb it and then push the introducer on. When I get done, a good portion of the time it doesn't bleed at all, but people that, you know, are on blood thinners, different reasons, some of my little older ladies are just going to seep around it. So I'm going to put gauze there, and I'm going to cover it with the sterile dressing. Oh! Oh, for heaven's sakes. Yeah. That'll teach them to let me use Peter PICC here. We need to run down to ER. We're having a disaster here. All right. Okay, so gauze, yeah, and then it needs to be changed the next day.
Having a head wrench.
Now, if you have to put gauze on it again, and sometimes you do if they don't, yeah, that's what,
okay.
yeah, I claimed it. It shouldn't do it anymore.
Oh my goodness.
We're just gonna give up on that part of it, because apparently there's a,
Description so deep, is it
Can you
turned
use
on?
that blue cloth?
yeah, I think it
Can
is.
you use this blue cloth that's in here?
Sure.
Isn't there a absorbent thing in here?
Yeah, no, but
Just use the blue cloth.
yeah, just
Blue
grab
cloth.
that blue thing and just lay it down here. It's kind of repellent, but it might help. And I clamped it all there.
Do you have a waste basket there?
I don't think it's gonna, see how nurses are? I love it. I don't think it's gonna, I think I clamped it
Yeah, it
off.
should stop.
Okay, all right,
Put it over and that's how they can just.
Right there, there's the waste basket.
yeah. When I first put PICCs in, that might have actually happened. I don't believe it.
You can
Okay,
just put everything in the trash.
there you go. We'll clean it all out. Yeah. But if you get it and it has the bio patch and then the stat lock, that's this white piece. I don't know if you guys have those if you do a dressing change. It's good for a week, and that's what I